What stuck with me the most was, especially like 12 years back, I would say, after my kids were born, I suffered from postpartum myself, not realizing I had it. Having that stigma of not being able to talk about it because of the South Asian stigma, especially, it made me realize, we need to have advocates. We need to talk more about it because there's nobody talking about it.
Well, welcome to Power to the Patients. I'm Brandon Lee, and today I'm joined by Sonia Prashar, the founder and CEO of AIM Trials. Sonia has over 18 years of clinical research experience, focusing largely on mental health in both pediatric and adult populations. She's also a passionate advocate for breaking the stigma around mental health, and her team is pioneering a lot of really innovative research techniques across AI and DCT, decentralized models, in order to expand patient access and improve outcomes. So, Sonia, welcome to the show.
Thank you so much, Brandon. Thank you for With Power.
Oh, that's too kind. But today is not about us. Today is about you. Sonia, before we get into the kind of nuts and bolts of what AIM is today, I'd love to hear what inspired you. How'd you get into research in the first place?
So research in the first place happened so many years ago, like 18 plus years ago, thanks to my PhD professor at that time, who did not think I was a right fit to be in the lab. And clinical research was not something that people knew back then at all. It was the three-part paper CRFs. And Merck at that time needed CRAs to work for urology and oncology. So it was during the spring break time. He just said, well, why don't you try this and then see if you like it? And I got pushed into the world, or inspired, gently nudged, whatever you can say, into the world of clinical research. And I never looked back.
So something must have stuck for you then,
Yeah.
when you got nudged in there. What was it that really took hold?
What really took hold, a very good question, is seeing the results. Understanding research isn't just about being in the lab, looking things through the microscope. Like, when clinical research industry is a different type of research, when I'm a person who is, my personality fit through talking to the patients, involving myself with the community, and getting that positive feedback and realizing, wow, this is such an important work that I am doing beyond the lab. That just stuck with me.
Yeah, yeah, and certainly so many, I think, of the powerful stories we hear come from the day-to-day work with the individuals who choose to participate in the research, and they're really the heroes in all of it.
110%. You see the real time, you get the real time feedback, and you realize this is why we're doing this.
Yeah, and psychiatry research, like how did that happen?
So I tried different types of clinical research. I'll be honest, like from dermatology to, I was actually including cardiothoracic, TAVR procedures, including AFib procedures, EP, everything. In and out, I would come back and forth between mental health. What stuck with me the most was, especially like 12 years back, I would say, after my kids were born, I suffered from postpartum myself, not realizing I had it. Having that stigma of not being able to talk about it because of the South Asian stigma, especially, it made me realize, we need to have advocates. We need to talk more about it because there's nobody talking about it. And I think it was around, my kids were around 3 years of age or something. And I just had an opportunity to just get back into research again. And because I'd taken a little break at that point, jump back into research and into mental health with intent that I do want to talk about mental health, the stigma associated and surrounded with it. And there's so much research that still needs to happen, especially in pediatric. There are so many different types of, like postpartum being one of those.
Mm-hmm.
Our communities need to know that it's okay to talk about this, and help is needed.
Sure. which is maybe a nice, I think, transition into AIM trials. So tell me a little bit more about the work you're doing.
So at AIM Trials, we are a research site. We work not exclusively in mental health, but about 80% we are into mental health, pediatric, adults, geriatric. We have investigators who are board certified in psychiatry, PhD psychologists, nurse practitioners, mental health nurse practitioners as well, psychedelics including. And one of the biggest, I would say, for anybody who comes and visits AM Trials, one of the biggest takeaway message would be everybody there is very passionate and compassionate, both. Passionate towards research, passionate towards the topic of mental health, wanting to break the stigma, but compassionate towards the patient care, understanding that patient is the center of it all.
I think running in this space, working across psychiatry research, it's obvious that it's certainly not an easy field to do research in. What have you found to be critical to doing great research in psychiatry?
Critical, keeping the patient in the center and the focus. I know with technology advancements that are happening, people talk about AI day in, day out. Especially these days, there's more about it, especially with the chat GPT, OpenAI and everything. The critical aspect in mental health research is connecting with that person sitting across from you. Understanding where they're coming from and putting things into their perspective.
Well, let me be a little bit difficult. I think that in some of the conversations we've had with CMOs, they'll say that one of the hard things about psychiatry research is that the placebo effect is so strong, especially in a setting where building a relationship with somebody with severe depression or anxiety in a research setting can actually contribute to improvement in symptoms. So I totally understand the desire to want to, build that kind of empathetic experience for the individual. But then how do you balance that with trying to keep kind of clean clinical separation?
So with clinical separation, it's very, it's about making sure when your patient walks in, like you just talked about anxiety. I'll give you a very good example. So we had a patient for actually one of the studies that I guess we all are working on together on. And
We can't say which.
we can't say which right now, or we can, I don't know. But so he walks in, reads the consent, everything, understanding there's a placebo effect to it. And it is important at that point of time to literally sit through and make them understand, like, hey, you're not here to please me. And that's where I'm talking about connecting with them. So you cannot really take away the clinical care part of it. Or you can just substitute it with making them understand, like, hey, you're not here to please me. This is for you. And if you are not able to tell me what's going on, we won't be able to bridge that gap. So making sure you understand where this person's perspective falls into where they're coming from. And at the end of the day, it's a detailed informed consent. So it is not easy, but somebody's got to bridge that gap.
Yeah. I think that a lot of folks would say that you've kind of you've operated through a really exciting time in psychiatry research. Let's say over the last
good times,
the good times, last 10 years.
Mhm.
How have you seen the landscape evolve, like in those 10 years? What's new? Where were things before?
A lot has changed in last 10 years. So much. We're talking simple things, right? In our personal lives too, things that we growing up didn't have, which is social media, right? Let's talk about that in a personal perspective, putting it into personal perspective. Today's kids or today's new adults, young adults have to deal with the anxiety of oh my God, somebody's putting this on social media. Mental health itself has changed. A person's perspective post-COVID changed. So the landscape changed so much with all these added technologies, the peer pressure, the expectations, that research had to adapt to it.
Hmm.
The use of marijuana increased.
Hmm.
Are we accepting that? How do we now mitigate that situation?
Mm-hmm.
With then we talk about, contraception. That changed, that landscape has changed where we're seeing a lot of now new protocols adding the use of oral contraceptive, which wasn't the case in 10 years ago because there were not that many.
Hmm.
So research in general has changed. Mental health research has changed even more with s- situations around us,
Right.
keeping in mind the situations around us, including COVID.
Yeah.
And so protocols, like you said, 10 years ago were sweeter the times, and now it's just getting tougher and tougher.
Yeah. Well, it seems to be the arc of research that it gets tougher and tougher. I mean, look at oncology and the way that that work is getting done now.
I stepped away from oncology so many years ago. I tried back going and I just couldn't because again, like you just said, it's the landscape's changing everywhere. The expectations are changing. And of course the guidelines are getting stricter, which they should, because it's adaptability at the end of the day. And we have to, basically be relevant in some way or the other now.
Yeah, absolutely. Uh, what maybe kind of like changing gears. So things have changed a while or changed a lot over the last 10 years. Um, what do you think that sponsors don't quite get right today in this kind of like climate of how research is happening today?
Hybrid models.
Okay.
I don't think we talk so much about decentralized trials. We talk so much about, oh, wow, decentralized trials are going to be game changer. Everything's said and done. Technology's gone so far, but research has not adapted technology to its fullest. Research has not yet come to terms with it. If you look at it as a society, people are busy compared to what they were 10 years ago working. Both parents are working now in case of pediatrics, right? Hybrid models or decentralized trials are still not implemented like they should be. We talk about, oh, AI is taking over, but have we as a research group actually implemented those? And sponsors are still hesitant, but I think they need to start implementing that because that will not only reduce the burden on the patients, but also the site staff. You're getting real-time data. And that's when, at the end of the day, the technology is going to go over.
This is so interesting to me. So talk to me about um, let's design a protocol from scratch, actually. Let's design a protocol. Uh, how would you like to see hybrid techniques used more
I love
in a
that.
prototypical like depression study, an MDD study?
Oh, I
Like
love that.
where should it go? Yeah,
I'd love that. Let's take into example just a depression, 18 through 65 years of age,
sure.
3-month study.
Hmm.
Let's assume total of maybe 14 visits. Let's have patient come in for screening visit,
Of course.
right?
Makes sense.
Paperwork, everything, blood work, ECG, easily can be done on site.
Uh-huh.
Split the screening visit into 2. Allow the patient to have the remote one-on-one with the psychologist or the psychiatrist or the investigator at site, the PI,
Uh-huh.
remotely, reducing that burden.
Huh.
Now you're not asking the patient to come to site for spending 3 hours straight. You're telling them, hey, I need you to come just for an hour and a half. We're going to do the initial screening of intake, consent, medical history review, everything, EKG, blood work, vital signs. Let me get all of that information, schedule a second screening part, which is a hybrid model where you're seeing the patient over the phone via Zoom, telehealth, for your rating scales, your psych eval with the investigator. for the study. You're automatically talking retention here. Interest has increased. Once you qualify, let's have you come in for randomization visits. So I'll explain to you how to take the medication, everything. You have now most of the protocols implementing third-party apps on patient compliance. I will see you back now in a month. Between that, your medication dispensing will be done through a third-party courier. They'll do a home health visit to dispense the medication. We'll be seeing you in that 1 month period. I'll still see you, or our doctor will continue to see you weekly for the rating scales via Zoom, and the link will be sent to you. We'll review your compliance on the third-party app to make sure you are really taking the medication like you're supposed to. Again, we've reduced the burden on the patient to come weekly. We've reduced the burden from the patient about taking time off of work. And your retention has now increased by tenfold. I'm not having to take time off.
Totally. So this all makes tremendous sense to me. Why not? Like, if we're going to steel man this, like, why not do it this way?
Like we worked with actually good, and see, that's a good point. Why not do it? So FDA actually released guidance about about use of AI in research in just January 2025, right? And we're still, which shows their flexibility. They're ready to adapt AI, but sponsors are still hesitant. Is it because the technology just isn't available? Is it because of the cost? That remains a question. But at the same time, on the site level, if you're looking at it, I'm on the operations ground level here. I hear these stories from patients firsthand, like, I can't take time off. He's a great patient. I know this is a great candidate for the study, meets all the criteria. They can't just come in that often. Psychedelic studies, and if we can do the prep sessions, the integration sessions remotely, we're automatically reducing the burden from the patient's endpoint, because it's a lot to ask, especially now that people are having to go back to work full time. The way the economy is, layoffs are happening everywhere, inflation's on the rise. We need good patients, but we also need to understand, hey, this is real world.
I think especially in psychiatry, where the scales are done, you know, can be done remotely. Um, it can make a lot of sense. But surely there's something that sponsors are scared of when they design this research.
I'm curious, as curious as you are, because I think where I stand today, I love embracing technology. I really do love embracing technology because it should be used to augment. It's not replacing the human connection or anything. It's here to empower us. And if we are able to do so, then why not?
I guess the only argument that I think ends up circulating in my head is there for some reason um, a hypothesis that the data might not be as clean? Like, we were talking about the placebo effect and how in psychiatry it's like particularly difficult. Is there, like, for some reason that um, it'll make it harder to separate?
I don't think so. I really don't think so, because we're using technology to bridge that gap between, we're using that to bridge the gap, which we're talking about gap as in we're augmenting, we're empowering this patient to be even more receptive. Retention is, because at the end of the day, it's about data, right? It's a cleaner data. I also have a counter argument to that for certain studies where I'm having a patient to come to my clinic for a visit, but this patient just had a hard day at work because they had to leave work to come here, fought traffic, 40 minutes. When I'm sitting front in front, they're also keeping in mind they just had to sit in traffic for 40 hours. Their blood pressure's up. They're, basically not in the frame of mind because they are just still going over and over about what happened in 40 minutes of that traffic.
Yeah, there's an interesting argument to be made that like actually,
right? And so when I'm talking to you about it,
yeah,
so but at the same time, when they're sitting right across in front on a Zoom camera, they are much more present. They're much more present in the moment. They're able to give much more cleaner information, and they're not worried about, or we're not worried about, oh, are you talking about the 40 minutes of traffic that you had? Like, is that influencing your information? The patient's much more at their comfort,
yeah,
especially anxiety studies, if we talk about.
totally. Yeah, like there's an interesting argument to be made that actually having more remote data or like hybrid data kind of like capture is a more authentic view of the kind of individual's experience because it's like in their day to day as opposed to in a kind of contrived setting almost.
Well, and in certain cases, we're also reducing the burden on the families
Oh yeah, of course.
because there are caregivers who are having to come, but it's not the caregiver who's the patient, but they're having to take time off. And we have to take into consideration when we're building the protocol. And like we did a study a while back for a very rare disease for Duchenne's muscular dystrophy. And it was a complete decentralized trial on adolescents. And we saw about 60% increase in recruitment, 100% retention. Everything was done remote, including sending medications, everything, because that improved accessibility for patients and the caregivers with remote monitoring visits and wearable devices and everything, with home visits included. That also increased diversity. We're talking patients we want diversity in our trials. With hybrid models or decentralized models, we are now actually able to reach the rural.
Hmm. Of
We're
course,
able
yeah.
rural where these patients probably it's inconvenient for them to come to these centers. Why not take research to them? And I was actually talking to last month to um, what do they call them? The government uh, and embassy folks. I was talking to Canadian embassy folks from Canadian embassy folks right here in Dallas. So one of them actually was from their healthcare ministry. So he and I had a meeting, and they want to see how we can help them build a protocol for rural population in Canada, take research to them because they don't have accessible transportation, especially in winters, accessible transportation to come to metro cities. How can we basically, like, we're helping them build a protocol just around decentralized trials.
Right. You seem to have a lot of ties to Canada. What's the story there? I'm Canadian. So what's the story? You've told me a few stories about Canada today.
It's like one person talks to another person, they refer
Yeah,
me, and it's just that. It's just purely networking, one to the other to the other. That's all it is. And
that's
that's
so
all I
funny.
think research is too. We're actually working with the Canadian Health for one of your provinces. We're working with them here to help them with understanding how. So they basically have two pharmaceuticals that they they're just Canadian pharmaceuticals that need help in getting help to patients in rural Canada. And I think it's great. Why not?
Yeah, I mean, it's interesting to hear that you're kind of plugging into the rural Canadian challenge. I mean, it is just as big a challenge in the U.S. Engaging rural populations, especially with mental health.
Absolutely. Absolutely. I mean, across the globe, and I think mental health is one such area where remote, hybrid, decentralized trials can be easily implemented.
So let me be difficult again. This is the theme of the podcast.
Absolutely.
We talk about something and then I steal man it. Do we strictly need to increase access in research specifically to rural populations? Or can the research be sufficiently done with folks who have direct access already to brick and mortar sites? I guess, is there a research imperative that requires us to engage with those folks?
Absolutely, it's needed. When you talk about brick and mortar, you're talking about patients coming to me. We're talking diversity. 2024 FDA's regulations wants more diversity. In a metro city, even such as DFW, Dallas-Fort Worth, we have so many different research sites. There's thousands of people coming in day out. But what about the ones who live 2 hours away, have no accessibility around them? And that's a big town. It's a large population. What about them? We need diversity. We need to start going to them. We can't expect everybody to come to us. It has to be two-way street here. When also you're talking about Texas in general, it's such a big state, right?
I guess like the thrust of the question is, hey, this study is looking for 200 participants, 500 participants. Surely there are 500 participants within a 20-mile catchment area of the research sites.
But also those 500 patients, think about those 500 patients we're talking about. We're talking about a certain mile radius.
Yeah.
Certain mile radius from the brick and mortar site, right? It could be saturated with only one ethnic group or two or three ethnic groups. We're not talking about the other ethnic groups that are outside of that radius of the brick and mortar site. So those 500 patients cannot be just simply be 60% of one ethnic group, 20% of one ethnic group. If we want data, a true clean data, we also want this medication to work on, like genetically speaking, on different ethnic groups. We have to spread that mileage, that radius from the brick and mortar site. But we certainly can't expect this person from rural to come here 2-3 hours away, leaving their job every 15 days.
Yeah. Yeah, absolutely.
But also when I talk to one person from that ethnic group who recommends another person, I'm slowly increasing my pool.
Yeah. So you're clearly passionate about the use of this technology in research, but it must be frustrating, I guess, as a site, because the decision making around the use of these tools happens with the sponsors. So how do you engage? How do you try to make the change that you want to see?
I think you know it well. I'm very vocal.
Sure. Yeah. You have to be.
Not present to hide. So every opportunity that I have I'm the first person to say, hey, we need this.
Yeah.
Because like anything else, like I told you, when my own story with postpartum, I realized when I was going through it, there was nobody talking about it. I said, you know what? I have to talk. If I don't talk about it, then you know what? For the change to happen, we have to be the change. We have to talk about it. It's not going to be overnight. But there could be somebody who is in the similar boat or in the same process as me, but just is afraid to talk about it because of the repercussions. But I want to talk about it because if I don't give the real feedback to the sponsors, they're never going to understand the real operational challenges on the ground. So every opportunity that I get to meet with any medical directors, CEOs, anybody, I'm very vocal about it. Be it budget, be it implementation of technology, be it implementation of hybrid models, home health visits. I'm very vocal about it because the feedback is important.
Yeah. I guess the you would know better than me, but the kind of frustrating reality of adopting innovation in this space is that it kind of has to start in phase 1 or phase 2. Otherwise, otherwise nobody wants to do the brand new thing on phase 3.
Agree. I agree. But you and I know it better. That's on the sponsor ends, things are a completely different ballgame. Like I've come from a sponsor side and I understand the vendor's situation. And that's where I'm going back. Do we just not have the technology? Or because I look at other industries and I realize, wait a minute, look at how the technology advancement and adaptability is. Why are we so behind?
Right. I get asked that all the time.
Like, why are we so behind? And what is stopping us?
I have an opinion, but I'm curious if you have an opinion.
What is yours? Let's start with that.
Uh, my opinion is that the nature of clinical research requires things to be very stable for long amounts of time. In order to have clean data and clean research, right? You're going to run a study for 2 or 3 years, and you actually want the conditions in your month 1 to be the same conditions as month 24. And as a result, it is a lot harder, I think, for folks to iterate quickly. The iteration cycles on techniques and technology take a year or two because of the nature of needing similar conditions. Whereas in a lot of other spaces, you could build a new product next month and try it out. Or, I mean, God forbid, on social media, you can build a new product tomorrow and then millions of people get to try it. Whereas because research requires similar conditions in month 1 and month 18, the speed of iteration takes a lot longer. And then as a result, we can't evolve this quickly. At least that's my take.
I personally feel it's lack of knowledge. I personally feel it's a lack of knowledge. It's not so much of, because if you look at it on the ground level, we just came out of COVID like a few years ago. Things changed overnight. Business was as usual after a few months. People were, research, of course, some of it stopped, but some of it continued, right? Problem was nobody knew what to do because of the lack of knowledge, of adaptability towards the technology. Humans in general, if you look at it, we adapt to things faster. That's the whole thing, right? We adapt. What you're talking about, manufacturing standpoint, I get it. It has to be consistent environment, consistent things. But when we're talking about humans and mental health, it's never going to be this. It's like an EKG graph, up and down. Mood swings are going to be there when you take a bipolar patient specifically, or a schizophrenia patient. You are probably at a better chance of doing a hybrid model where if a patient's having is having a crisis, a mental health crisis, instead of burdening the patient to come to the visit, and burdening the site to constantly having to follow up with this patient saying, hey, I need you to come, reminder, reminder. This patient's already in crisis at this moment. This patient does not need to be burdened with more. We need to adapt to do home health. Give us that option. If you can't implement 100%, put that as an option saying, hey, in cases like this, psychs can go to the patient. Home health is an option. Hybrid is an option. You're now not having a patient who's saying, I'm not coming back to your site. I don't want to come. You've lost this data completely. Sometimes 6 months worth of data wasted because this patient early terminated because of that one moment.
Which is frustrating.
It is 100% frustrating for everybody.
Yeah.
Right? But now you want to implement this, give them that chance. Let's work together. But it's the lack of knowledge of how to do this or implement it is what stops us, is the fear.
I think it's the fear, right? Because at the end of the day, this whole apparatus stops and starts at FDA approval.
Mm-hmm. But now, hopefully, with the new 2025 and I mean, I've read it and I like it. It just shows how FDA too is ready to adapt.
Yeah.
And they're flexible.
And I mean, I've had conversations with a lot of regulators who I think are like always like frustrated that they're seen as this bogeyman, right? They're seen as the boogeyman, but like no, they're not trying to stop research. They're trying to adapt to the moment as well while maintaining, I think the level of scientific rigor that is that's necessary.
Absolutely. At the end of the day, we are all here for the same thing: is keeping patient in the center of it all, not losing the touch, keeping recruitment as diverse as possible, making sure retention is higher, but without burdening anybody here, getting the cleaner data and making sure it's quality that everybody gets.
Of course, of course. And at the end of the day, if we do all those things, then we get to participate in this beautiful mission of conducting medical research and bringing life-changing treatment options to others. And that's kind of why we all wake up in the morning.
That's exactly why. And if we can do it, why not? Like I was like when we did with the DMD study, the Duchenne study, I was fast. It was impressive, Brandon. It was really impressive because it talked about like we were able to capture real-time data with the wearable device. We were able to capture real-time data, which we would have not been able to. And it was minimizing disruption in day-to-day life for parents and the children, financial liabilities, even coming, going like the whole thing. It was flexible. We were able to get more quality. In fact, we were able to capture more data, which further led to development of the second protocol.
It's the classic standing on the shoulders of giants, right? All research kind of builds on the research that comes before.
Oh, absolutely. Viagra
Yeah.
is a classic example here, like everybody says.
Oh, Pfizer. Oh, Pfizer. Sonia, this has been so fun. I want to close with a slight change of topic, um, which is that uh, you've been successful doing something that's really hard, which is building a research site. What do you wish you knew 10 years ago um, when you decided to embark on this?
What I wish I knew it was this hard. I, I really didn't know. I mean, if I have to tell myself that sitting across the room and thinking I can start seemed easy.
Ugh.
It sounded easy. But actually doing it, I realized it's way more harder. Way more harder because I don't think people understand the sacrifices that go beyond building anything. Like you have started with power, it is not easy. And to be constantly and constantly trying to be relevant when there is so much noise around, there's so much competition around, how do you stay relevant? How do you always stay ahead of the curve? And keeping all this in mind, but keeping your own mental health in check as
Sure, taking care of yourself. Yeah, at the end of the day, it's a
well.
marathon.
It is a marathon, and if you're not really aligned with yourself, you can lose yourself. And so
Uh,
10 years ago, I didn't know what I know today, of course, that it's just a cycle. And taking care of self is the hardest part because it's easy to get lost in this whole gamut of cat and mouse game.
yeah, absolutely. It's I'm. It's funny you say that. Of course, I get asked a flavor of the same question, and I think a lot of entrepreneurs will kind of echo that. Uh, uh, when you're just starting, it feels like taking the leap is the hardest part, but you don't actually realize how hard it is to keep it running.
Well, like I think it was who I forgot the name of the actor in Bohemian Rhapsody, the guy who won the
Malik,
Oscar,
Rami, yeah,
Malik or something. I think it was his interview where he said, "This is now where the hard work actually starts."
I
Because
love
once
that.
you have achieved something, you have to keep going.
Yeah.
You have no other choice. And that becomes so difficult sometimes because there are days you and I both know we want to get up and we want to go back to sleep.
Sure.
Like we don't want to take the red eye. We don't, but we do it because we're passionate for it. But people don't realize the sacrifices that go behind it. And that 10 years ago, I didn't know that it would be this hard. But I think it's important to keep mental health in check and forgive yourself. It's okay.
Yeah. Yeah. There will be uh, there will be lows, but there will also be highs.
There will be highs, there'll be small wins also coming through. In fact, yesterday I was talking to one of our psychiatrists. He said, Sonia, 2 years ago, that person you were, you're not today.
That's I hope that was a compliment.
Yeah, yeah, it was. And he's like, people will gossip because we were talking in terms of some gossip around, but those people are always going to be where they were. And they are, again, 2 years later, also, they're going to be there where they were, just gossiping about somebody else. You've continued to move forward. So it's okay to forgive because this won't be your first mistake. It won't be your last mistake. You're going to continue to make mistakes and just learn to forgive yourself.
Yeah. And the thing that I find myself kind of reminding myself a lot, and I don't know if this is familiar to you, but it's that everything is always hardest the first time. The challenge with running a business is that like there's always a next first time. You don't get to just solve the same problem every day.
Yes, I completely agree with you.
Yeah.
I completely
Yeah.
agree with you. It's always a new muscle that we realize, oh my God, we have to train
Yeah.
that one now.
Yeah. But the thing that was difficult 2 years ago now feels really easy.
Absolutely.
And that's a beautiful thing.
Yeah, I completely agree. And, forgiving yourself, keep yourself in check. It's okay.
Yeah. Sonia, this has been so fun. What what do you not get asked uh often enough that you wish you were asked more?
For me personally, I think what people don't ask is, I mean, there's always something or the other that's always new. But like you just said, it's more or less about people don't ask about or talk about the sacrifices that went along the way. People never ask, people always ask about the wins. Nobody asks about the failures. And I wish people asked about those failures more because the actual lesson happened in those failures.
Do you want to talk about one that's top of mind?
There's so many, Brandon. There's so
Maybe a
many.
topic for another day.
No, there's so many. And personal too, there's so many. And um, I wish people talk about that.
Yeah.
And more importantly, what I always tell people is that don't focus on what that person's achieved. Because it's easy to say, oh, wow, you're rich, you are driving this car, or you live in a penthouse, oh, you're flying to, you're staying at this resort. It's easy to judge. Talk about that the hard work that went along with it.
Yeah. Yeah.
Talk about that. And nobody wants to talk about the hard stuff.
It's certainly not fun at conferences.
No, 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 no,
Yeah.
no. And I'm usually one of those, you know that everybody I think who knows me knows I'm the vocal. I'm also the jester.
Well, some combination of that is delightful.
So, it's entertaining as well, but it's people I wish they asked more about the failures, not so much just about the wins.
Yeah. Well, the next time we catch up over a coffee or something, we'll have to talk about some of those failures because um, certainly some hard-won lessons baked in
Those
there.
are the hard lessons. And, those are the ones that teach you. Like one of my hardest lessons I learned how to drive in this country was a broken leg.
Oh no.
It started with a broken leg, having forced to start driving to go to the doctor's office,
Oh no.
be- and with a third degree fracture.
Oh no. That sounds
So those,
stressful.
but those, if it wasn't for that hard moment, I wouldn't have been forced to drive.
Yeah. And without that, you would not be here today.
That is true.
which is the moral of the story.
The moral of the story is it's okay. Do not be afraid of the hard lessons.
Do not be afraid of the hard things. Absolutely. Well, Sonia, I so enjoyed this conversation. I really appreciate you taking the time to get on the phone, share some of your lessons, share some of
Absolutely.
your wisdom in building AIM trials.
Thank you so much, Brandon. It's definitely a pleasure.
Yeah, likewise.